Okay, so this was my idea for the topic, diabetes, everyone's new best friends. And why everyone's new best friend? Because you're just seeing more and more people, all age ranges, presenting with diagnoses of both prediabetes and diabetes. And it almost seems like it's everybody's new best friend. You know, when you look around somebody who never even had a family history, suddenly is diabetic, etc. So I'm just going to go through some basic things that I think that you may need to know. I don't think there's anybody in this chat who doesn't know somebody who doesn't have diabetes, or maybe they have prediabetes or diabetes themselves. Okay, so do you ever think any of the following? What is diabetes? Why is it on the rise? How do I know if I'm at risk, and how do I screen for diabetes? I only have prediabetes. Why do I need to be worried? How do I control my diabetes? My diabetes is controlled. Are there other things I should be concerned about? I'm so terrified I'll get diabetes complications, something that I see all the time. How can I prevent myself from getting diabetes? Do I need to tell people I have diabetes? I find managing my diabetes as an older person hard. What about my children and grandchildren? I'm so stressed out, I just can't be bothered anymore. COVID has made me so terrified as a person living with diabetes. So if you ever thought any single one of these things, or anybody you know thought one of these things, you're at the right place today. So first of all, what is diabetes mellitus? It's often a condition that we call the sugar, and it's a condition where the blood glucose becomes raised due to what we call a relative insulin deficiency. So first of all, what's insulin? So insulin is a hormone that's produced by an organ called the pancreas. You can see in this image here, it's actually in the abdomen, and the pancreas is actually located almost like behind and slash underneath the stomach. You'll see the diagram, the stomach there, and just almost like kind of to the side and next to the liver. So it's almost in the back of the abdomen. And what it does is that it allows our body to use glucose, which is either taken in or made by our body for energy. So the glucose that circulates in our body is a combination of glucose, or people like to say sugar, that is a result of what we consume from carbohydrates or starches, and also what is made by the body, because the body can make its own glucose. So if I were on a starvation diet or whatever, I would still have glucose circulating in my body. So insulin deficiency occurs when the pancreas either cannot produce insulin, or the insulin is produced, but it does not do its job properly. So this is just a quick slide to show you, how insulin works. And when we explain to patients, we just use a very kind of simple, almost image. And insulin is almost like the key. You can see it on the left-hand side is the key. It goes to the cells. It opens certain receptors, and it allows the glucose, which are the yellow circles, to enter into the cell, where they can then be used for energy. Okay, so something very simple. And this is an important concept because it's important to understand that people with diabetes don't necessarily consume more or less sugar than somebody who doesn't have. The problem with diabetes is that the key either is absent, as in type 1 diabetes, and you can't get the sugar entering the cell, or the key is present, but it almost doesn't fit properly, and the sugar doesn't enter the cell properly. And that's how the blood sugar rises, is by improper, what we call flux or movement of the glucose between the blood and cells, where they can be burnt up and utilized for energy. So this is actually a simplified diabetes classification. So I mentioned type 1, where there's failure to produce insulin, and type 2, where there's insulin production, but the insulin does not function properly, or there's an issue with the receptor or the keyhole, so it doesn't work properly. But I just wanted to point out some other diabetes, other types of diabetes, so that you know that it's not just that. Although, mind you, type 2 is the most common and certainly accounts for about 95% of diabetes that we see, both locally and elsewhere generally. It's probably even higher than that in Barbados. But you can also have diseases of what we call the pancreas, so the part of the pancreas that produces insulin. And I'm highlighting this to point out that alcohol damages your pancreas, and we do see diabetes in long-standing alcoholics, or people who have had a condition called pancreatitis. So that's a plug for reducing alcohol consumption. Endocrinopathies, that's just a big word meaning if you have disorders of other hormone axes. So for example, you can have somebody who has an overactive thyroid who presents with diabetes. Okay, drugs such as steroids, some people on steroids for very long periods of time can in fact develop diabetes or other chemicals. And the very bottom highlighted, you see GDM, which is gestational diabetes. This is the diabetes that happens in pregnancy. It usually crops up in the third trimester of pregnancy because the female hormones, particularly progesterone, makes the insulin not work properly, or it increases that what we call insulin resistance. So this is a nice chart that I kind of pulled up, and it's simple. It is really like looking at worldwide numbers for diabetes, and it only goes between 2000 to 2019, but you can see how the numbers have increased. And this is just over a nearly under 20-year period, 151 million, up to 463 million at the last count. And it's estimated that we continue on our trajectory, be 578 million by 2019. I remember these are estimated diagnosed cases of diabetes. This is another chart here. Now this actually shows our prevalence in Barbados. So what's happened between 2010 and it was I don't remember the year, I think it's 2017. And you can see that there's an increase in the percentage of diabetes from 8% in 2010 up to 13.4%. And this is in people aged 20 to 79 years of age. All right, 2019, it was from the World Bank. And then, of course, we have another study. This is one that's often referred to and what a lot of our common numbers are derived from. This is the Health of the Nation study done in 2015. And what did they say? What did they find? In a cohort of people who were responding to surveys, 18.7% of adults 25 years and older had diabetes. So your prevalence rates will always vary depending on what age range you're looking at, because if you include a population where there's less diabetes, it may dilute the percentage, etc. But what was interesting here is in persons over the age of 65 years, they said the prevalence rates were as high as 46.5%. So that's really 1 and 2, so that's actually pretty high. So what is fueling this rise really in type 2 diabetes? Remember I said that this is the predominant diabetes that we're actually dealing with, although we are seeing small increases in type 1 diabetes throughout the world. It is really obesity and lifestyle habits, okay? And it's estimated that by 2034, 1 in 3 people will actually be obese. And what's driving this obesity? It's really our lifestyle, the things that we consume, our physical inactivity largely, etc. So what are some of the risk factors for diabetes? Having a family history of diabetes, okay? Having a BMI, so this is called a body mass index or a measure. This is over 23.0 kilograms per meter square. In the population, we put that at over 25. Leading an active lifestyle, having a high blood pressure. So yes, high blood pressure and diabetes are actually directly linked, and they have the same actual underlying what we call pathophysiologies or mechanisms in play that actually contribute to them. Having an abnormal blood cholesterol or lipid profile. So yes, if you have high blood pressure or if you have cholesterol issues, maybe yes, you should consider going and having a screening for diabetes. We mentioned the history of gestational diabetes. In those pregnant mummies who develop diabetes, some of them will revert to being normal. Some of them will continue to have diabetes, and some will develop it later on, down the road. Are you over the age of 40 years? And I like that they've reduced the age from 45 to 40 years, because this is in reality what we are actually seeing, on the ground nowadays. And of course, if you have impaired glucose tolerance or impaired fasting glucose, we can kind of bottle that into pre-diabetes, okay? But despite all of these things here, what I would say is that I think lifestyle factors can override almost any of these factors here. So even if you don't have a family history of diabetes, but you have a lifestyle that's conducive to developing diabetes, you are certainly at risk. So I am no longer in the camp that thinks you must have a family history of diabetes in a first or second degree relative to develop diabetes. So what is pre-diabetes? This is interesting. It's separated from diabetes. It's a condition where the blood sugar levels are higher than normal, but not high enough to be considered diabetes. However, in my opinion, pre-diabetes is just a spectrum of diabetes because you're still having abnormalities in the blood sugar. And it has actually been shown that those abnormalities in blood sugar, the ups and downs and the fluctuations, do actually cause damage at a very early stage. So this is why at diagnosis, sometimes we have persons who are diagnosed with diabetes and they already have complications. And it may also be because they had diabetes for a while and they didn't know, but it's important to understand that the complications and how that kind of derives actually starts in the pre-diabetic phase. So it's not as benign as we think. And nowadays, we certainly are treating pre-diabetes, both with lifestyle measures and metformin. And it's just important that if you ever heard, oh, your sugar's a little raised, but just do this, do that. Remember, it's not as benign as that. And it's actually very important that you take immediate action on it. So more than 84% of persons with prediabetes do not know that they have it. It's one of those kind of silent conditions, just as diabetes can be quite silent. Prediabetes puts you at increased risk of developing type 2 diabetes. Independent of type 2 diabetes, heart disease, and strokes as well. So you don't ever have to get type 2 diabetes, but it certainly increases your risk of the other conditions. So diabetes, knowing your symptoms. So we have lots of symptoms. People always go, what's the symptom of diabetes, you know? And I'm going to go to my right-hand side. The most important thing to understand is the most common symptom is absolutely nothing. And this is why screening is so important. And it's very important that you consider this as a part of your regular kind of healthcare, as opposed to waiting until you have a symptom. If you wait until you have a symptom, you've probably had diabetes or pre-diabetes, or for a little while, could be anywhere from 1 to 5 years, right? And if you've had it untreated and undiagnosed, it means that you're therefore at risk of having complications at the time of diagnosis. So regular screening is very important. So some of the symptoms might be, you may always be tired, you may pass urine more frequently as your body tries to get rid of the sugar in excess from the blood, you pass more water out as well. Sudden weight loss, wounds that won't heal properly, always being hungry. Remember what we said with diabetes, you have sugar around in the blood system, but the cells can't get it for energy. So the cells are actually going, why am I always hungry? That's because on the inside, the cells are actually starving, although there's this excessive sugar around. Sexual problems, blurry vision, vaginal infections, and also recurrent thrush on the skin, numbness or tingling of the hands or feet, and this is because the up and down changes in the blood sugars make the nerves very irritable, particularly the nerves in the toes and the fingers, etc. And of course, always being thirsty. Remember we said you're losing lots of sugar and you're using lots of water from the body, so you can tend to be very thirsty. So that's just a reminder. Most common symptom is nothing. Please make sure you get your screening regularly. So this is just looking quickly at the diagnostic criteria for diabetes and prediabetes. So there are a clear set of criteria, and this is actually the criteria that is not really commonly used. There are other criteria, but even in America, this criteria is being used, and this is certainly the one that we're using these days. I won't go through it, I think, in great detail, but I wanted to point out some things. You have something called your fasting plasma glucose. So that's the blood sugar that you're going to get in the morning after overnight fast of at least 8 hours, preferably. And to diagnose prediabetes, 5.5 to 7 over 7 would be can land you into the category of diabetes. You can have what we call an oral glucose tolerance test. That's where you drink something that's very sugary. But mind you, nowadays, you do not have to have an oral glucose tolerance test to diagnose diabetes. It is, however, recommended that you have at least the fasting plasma glucose and something called the HbA1c, which I will mention in a moment. Okay? If you have concerns about whether you do or you don't have diabetes based on the test, they may want to perform an oral glucose tolerance test. But nowadays, most people don't do that routinely for diagnosis. If you're looking at diabetes in pregnancy, however, the criteria are different, and you do have to do an oral glucose tolerance test to have that done, to diagnose, sorry. So this is just showing you very quickly just the other units, which some of you may have seen before. This is measuring in milligrams per deciliters. And nowadays in Barbados, we have machines that will measure both in the British units, or what we commonly use in Barbados, which is millimoles per liter, and the American units are milligrams per deciliter. If you have a machine that measures in these higher numbers, all you have to do, divide the blood sugar that you get by 18, and that will give you the reading in millimole. So in case you get stuck with one of those machines, you know how to convert it. And it becomes very second, almost nature once you start checking in the other unit to know, okay, well, you know, in the morning I want it here, after meals I want it here, etc. But just pointing this out to you. So what is the HbA1c? So we mentioned that as something that's used to diagnose diabetes. So the HbA1c, some people call it a 3-month average. It's not quite a 3-month average, but what it is a reflection of that, almost like the summated sugars over a period of time, usually 3 months, but it may be 2 to 3 months. And we generally check it every 3 months, however. And what it does is it measures the amount of cell that sticks onto the red blood cells in your body. So it's actually not a blood sugar. The reason that we do the A1C is because your blood sugar can be constantly changed, and it can be 5 in the morning, it can be 10 in the day, it can be 22 in the day and 5 in the morning. So what it is at a particular point in time doesn't always necessarily a good idea of what your overall control has been. We've certainly gotten a bit more technical than just looking at the HbA1c, and there are other monitors that can assess things like time in range and things like that. But this is the common thing that we would be looking at in Barbados in terms of looking at our average control. And you can see on the red blood cell on the left-hand side, there's less sugar overall in the 3-month period. So it has less sugar that's stuck onto it irreversibly. If the blood sugar is more over that period of time, you will have more sugar sticking onto it, and the A1C would therefore be higher. So the A1C is affected by how long the red blood cell lasts. So if you are breaking down your red cells very quickly, A1C might not necessarily be the most accurate kind of determination of what your average sugar reading has actually been. So this is a nice one. How often should I be testing? Magical question. And these young ladies make testing look so easy. They're doing their synchronized swimming. They've got their little glucometers on little floats, and they're testing their blood sugars. And to some people, that unfortunately is so far from the truth. But what I would like to say is that if you're doing testing, make sure that you know how to use your equipment. Make sure you know how to use your lancet. Make sure that you're changing the needles to stick yourself. So this is something very simple. But it's a common mistake that we see very often. People don't change their needles frequently, so they're sticking themselves with dull needles. And therefore, it means testing becomes an enormous kind of mental burden because every time you do it, it hurts. Make sure you have your lancet set to the lowest setting that will give you blood, so you're not doing deep sticks all the time. And make sure you're testing at different sites. Now, as to how often you should be testing, really it's very variable. And it's really something that you should discuss with your care provider, which is why I haven't given you a magical number there. And it depends on the person as well. If you're using insulin, yes, it's recommended that you certainly should be testing your blood sugar. Depending on the number of times you use insulin, the type of insulin you use, the number of times you check your sugar may vary from anything between once to 4, 5, 6 times a day. It depends on your insulin schedules that you're using. Some people use insulin once a day, some use it twice, some use it 3, 4 times, some even use it with snacks in between meals. So for some people, for example, type 1 diabetes, they may be testing their sugar 6 or 7 times a day. Okay, if you're using tablets, you can test less frequently, but it depends on what you want to derive from testing. So people do testing to find out, well, how their blood sugar control is. My best suggestion to people is when you're testing your blood sugars, if you're on tablets, check it at different times of the day on different days. You don't necessarily have to check it every day. So say maybe 2 or 3 days a week, but always do it at different times. So in the morning, before lunch, before dinner, before the evening, because when you compile those after 2, 3 weeks or a month, you kind of get an idea as to how things are almost like running around the clock. If you're only testing in the morning, that gives me actually almost no idea as to what is happening, because as I said before, your blood sugar can be 5 in the morning, but it can be 20 in the evening. And you will miss those highs if you're only testing at one specific time of the day. I do have to say, in all fairness, research out of the UK has actually been shown that for certain people in the UK on tablets, Testing really does not make that much difference to control, and it's not necessarily recommended that you test frequently. I'm on the camp of testing. However, I believe in knowing and seeing, because in my experience in Barbados, what testing has done, it keeps people almost like on the ball. It keeps their eye on the prize. And whenever I have patients generally who stop testing, even if they're on tablets, they come back with their blood sugars higher. Why? Because when you check your sugar and you see it's a little bit off, it almost sends a second message to you that says, okay, what do I need to do differently? Okay, maybe I did that and maybe I shouldn't do that again. Or maybe I don't need as much as that. And that has been my general experience in terms of testing. So I think people are very responsive to testing. So this is another slide, and it's just going through really common diabetes treatments. And to my mind, nice slide, ordered in the wrong way slightly, okay? So I'm going to jump on the one in the lower right-hand corner, diet and exercise, okay? So for diet and exercise really is recommended for any type of diabetes, type 1 or type 2 diabetes. Diet, I'm not too keen on the word like diet as in diet. It's not really like diet, but it's about having a healthy kind of balanced diet. I mean, if you do need to go on to a diet to lose weight or something like that, that's fine. But the reality is you do have to keep your eye on what's going on with your food. If I go out to buy food from a shop or a van somewhere, the reality is that can probably feed me 3 times. We actually generally eat way too much food. Our portion sizes are massive, and all the starch that we consume, that is all converted into sugar and makes blood sugars quite high. So you do have to think about things like your portion control, how you're balancing your diet. Do you have enough fiber in your diet? Because that actually smooths out how those starches behave and stops your blood sugar from spiking. Are you mixing maybe a bit of protein or a bit of healthy fats, with your starches, etc.? And then, of course, we have physical activity as well. So if I had pre-diabetes, I would say numero uno, diet and exercise, number one, number one, number one, number one, and number one. Okay, this can actually help you put diabetes or pre-diabetes into remission. Remitting diabetes is certainly easier if you've had it for a much shorter period of time. Longer period of time, it can still happen, but it's a little bit more difficult, generally speaking. But you know what? Even if you are on medication and you have a healthy, balanced diet and exercise, you will tend to be on less medications anyway. I've had patients who after 20 years have come off of insulin through changing their diet and their exercise, okay? So then, of course, after that, we have oral medications. So these can be used in people with type 2 diabetes. And mind you, there are 1 or 2 orals that are non-licensed, but are used in conjunction with insulin for type 1 diabetes. So remember, we said type 1 diabetes is not insulin. So that means in type 1, you do actually need to take insulin to survive. Insulin in type 1 diabetes becomes a life-saving medication. You can also use, I'll move on to insulin. So insulin, we have that in people with type 1 diabetes. And then, of course, with type 2 diabetes or gestational diabetes. So it's important to remember that both type 1 and type 2 diabetic persons may have a need for insulin. Insulin doesn't define whether you're a type 1 or type 2. It is the underlying what we call mechanism or what's going on as to why you have diabetes that makes you a type 1 or a type 2. So insulin can be delivered via injections, which would be the most common thing known. We do have insulin pumps. They're not widely used in Barbados simply because they're not covered by insurance or the drug service. So it becomes a very expensive endeavor for people to use insulin pumps. There are some inhalers, newer inhalers now, which have a more predictable blood sugar lowering, but they are not available in Barbados. The early inhalers that were developed did not produce as predictable lowering, and they kind of just fell out of the market and out of use as well. So I like the common diabetes treatments. I love that they've put home glucose monitoring here, okay? And this is because when you know what's going on, you're really in control of your life, what's going on, how you eat, and you're able to inform yourself better. So I've included this more complicated side because yes, although we have common diabetes treatments, and that sounds very like, you're like, yeah, I know this, I've heard all of this, but really and truly, this is what diabetes treatment should really look like. diabetes treatment should be designed for the individual, i.e., meaning you need to discuss your treatment plan with your doctor, your nutritionist, and your educator. So while it's great to get advice from family members and other people you may know, you really do have to have this dialogue with your care provider. Um, because there are a lot of people who mean well, but you have to remember that diabetes behaves so very differently in each person. What works for Sally will not work for George, and how a medication works in Anne, it will not work the same way in Tommy. Okay, and so part of diabetes self-management, first of all, is actually understanding the diabetes process. It's not good enough to just treat people with medication and people do not understand. Why? Because those are the people who become non-compliant. Those are the people whose blood sugars go up and they don't really quite, they're not able to act on it because they don't have that understanding. They get frustrated because they don't understand what's going on. They don't understand their medications, how they work. We have nutritional management. You cannot manage diabetes if you do not know how to manage diet. And while there are things that we would say are a healthy diet, when you have diabetes, you have to understand nutrition in a very different way from just having, oh, I have a healthy diet. Oh, I'm eating breadfruit, it's healthy, so there is no problem. It's not a matter of problem, it's as to how you manage it for you, your body, and where your diabetes is on its spectrum. Physical activity needs to be clearly built and tailored to what the person can do. So because I can walk up and down the road, it doesn't mean that my 85-year-old grandmother can do the same thing. So what's the point of me telling her to go and walk when she has back pain and knee pain and she cannot walk? How to utilize the medication properly, correct timing of medication. Medication must be timed relative to food in most cases for diabetes. The question is does it come before food? How long before the food does it come? Does it come with the food or after the food? How you use the medication makes a massive difference to how it controls your blood sugar. If you're using insulin, how is the insulin spaced? Do I use it 12 hours apart? Do I use one dose in the morning and one at lunch and one at dinner? These things matter greatly, okay? Learning how to monitor your blood glucose, and there are different systems for glucose monitoring, including the sensor, which you've probably seen. It's a wearable sensor, and you can just pass almost like a phone or a reader over it and get what we call them interstitial glucoses, which are a reflection of your blood glucose. Preventing, detecting, and treating acute, and I would say chronic complications as well. Goal setting for health and daily living. Psychosocial adjustments for daily living, okay? So if I have the elderly person who's at home and they can't manage, how are they being helped socially? What's the point of me of giving them insulin to take 4 times a day when they can't even see? Okay, promoting care during, prior and during pregnancy. So this, my friends, is really what diabetes management looks like, not this simplified version that is seen here. And it's important that you have these discussions with your care provider, because if you cannot cope within your environment, you're not going to succeed with your diabetes management. There is nothing about, medication is important, but you have to use that medication in the right context with the right support. Otherwise, the medication could cost you $300 a month. It's not going to control you if you don't get these things like your nutrition right and how you're managing within your environment and working out a plan that works for you. If you are a shift worker, how can you take insulin that you take twice a day that you can't actually take at those times because you're actually sleeping at that time? So simple things like that. I know I'm going on, but this is actually one of the most important things. And it is what we see people, when persons come to diabetes center, these are where all the challenges lie, is within the practicalities generally of management. So we mentioned balanced diet, and I'm just going to show you all of those things there. Of course, everything won't apply to everybody depending on what other medical conditions you may have going on or what other comorbidities or conditions you may have. So say, for example, if you had hypertension or whatever else, or if you're taking warfarin and blood thinning medication. But once again, that is why I said something that needs to be discussed with a nutritionist, because it needs to be individualized to you, your medications, your other medical conditions, etc. Please do not underestimate the importance of nutrition. What happened 10 years ago might not be relevant to what's happening 10 or 20 years down the road. You are a different person and a different body. And so just seeing a nutritionist once in your life with diabetes tends to be largely inadequate. And of course, exercise. We mentioned exercise already. So exercise is important for weight management. Even if you're exercising and you do not lose weight, hopefully you won't be gaining weight, okay? So it also decreases the risk of complications like heart attacks, increases cardiovascular health. You get better blood pressure and cholesterol control when you are exercising regularly. Exercise, as many of you know, also reduces your blood sugar. And how it does it, it varies between people, but you know, exercise is great in that it almost bypasses that insulin whole kind of mechanism. It actually makes sugar channels open up and the cells actually take the sugar out of the blood and into the muscles for energy. And the good thing about exercise is that the blood sugar lowering impact of exercise can last for up to 36 hours or so. So this is why we recommend that people, you know, exercise several days a week. So don't like Friday, Saturday, that doesn't benefit you from the blood sugar lowering perspective throughout the week, okay? And I think the most important thing about this slide that I love is that exercise can look like really anything. I always think people should do things that they enjoy, but also it should be tapered to what you can do physically. You can be in a wheelchair and you can exercise, okay? So there isn't anybody really who can exercise, I guess, unless you have a stroke and you're in a bed laid up completely and you can't do anything at all. Don't think that you can't exercise maybe because you have an amputated toe or you're in a wheelchair or maybe you've had a stroke and you have a weakness in some part of the body, okay? And then of course we have increased energy and strength. Another big one here, rethink your drink. So I want to look at these slides and you can see we have a water bottle there, no sugar. Some of these you will know, there's a little box juice there with chocolate milk. So chocolate milk, like some of the children say, they go, oh, it comes from a cow. No, it doesn't come from a cow. It's artificially produced and it has an added sugar. You have to remember that when you're a diabetic and when you're dealing with fruit, fruit is our natural God-given sugar. It's still sugar and the body treats it as such. And so therefore fruit juices, you have to think about fruit juices in a different way, really. Even a cold pressed fruit juice, you have to understand that it's sugar. It's not meaning that you can never have a fruit juice. Certainly if you're just on tablets, but you have to put everything into context and think about how you balance that diet and maybe how often you may be consuming that. We are generally not advocates for juices and soft drinks. You can see the Coke there. The Coke is just jumping off the screen with sugar. Now, one teaspoon of sugar is 4 grams, okay? So when you drink a Coke that has an over 50 grams of added sugar, do you understand how many teaspoons of sugar you're actually putting into your body? So what would ever make you think that a tablet, insulin, or anything else could actually outrun this sugar that you're putting in? The thing about these sugars is that because they're literally just pure sugar, your blood sugar starts rising as fast as anything. From the time that drink hits your mouth, you start absorbing that sugar and your blood sugar starts climbing the ladder very quickly. Even if you're taking insulin, a lot of times the insulin can't catch up with the sugar from sugar-sweetened beverages. So it's interesting sometimes when you have clients who come in and you see the sugars are up and down, or high in the morning. It's like, so what are you doing? So it's like, what are you drinking at night? Milo before bed. It's like, okay, there you go, you know? And sometimes you can be doing brilliantly with your diet. And you know what? It's actually the beverages that are getting you. Remember the Ovaltines, the Milos, even something as simple as a ginger crystal sugar tea is loaded with sugar, and it will make controlling your diabetes extremely difficult. And I would even like to say, wouldn't call any names, but I've met some lovely patients from SIL, some of them who come down, and some of them, when we looked at what was going on and they were spiking a bit. What was it? It was the beverages. It wasn't the food that was the problem. It was the beverages that they're consuming. Remove the beverages and what happens? The blood sugars come down really, really nice. Okay, so that's just always a reminder. You can't outrun that kind of sugar. So what if your diabetes is controlled and you're like, well, but my blood sugars are good. Do I really have to worry about anything else? You still do have to be concerned about other things. You have to remember that there are certain things that work in tandem. Obesity, in some cases, in most cases, hypertension, and dyslipidemia. these all cause, can potentially cause damage to similar organs. So when you start putting one condition with the other, you can understand that your risk of getting damage becomes higher. So you can have somebody with diabetes, or diabetes is controlled, but their hypertension is not controlled. They still end up with the heart attack, the stroke, the kidney failure. Okay. So it's important to understand that obesity, they still end up with heart failure, although their blood sugars are controlled. So you have to think about managing everything kind of together. So it means really about having an overall perspective on your health. It's not just about the blood sugar numbers, everything matters. Okay, so this is just a screen showing weight categories. The first one is kind of based on BMI. Remember, I would have mentioned overweight being 25 kilograms per meter squared and over. So how you measure that is you measure your weight in kilograms and you divide it by your height squared. So if I was 56 kilograms, it would be my weight in kilograms, 56 divided, if I am 1.2 meters, 56 divided by 1.2, and then divide that by 1.2 again in meters. So that's how you calculate your BMI. Another very important concept is waist circumference, because you can have somebody who has a normal BMI, as I have seen in clients here, but their waist circumference might be a little bit big. Just going back, if you went back to the first picture where we saw the abdomen, you have to remember the waist circumference tells you about, yes, fat around the waist, but the fat around the waist represents also the amount of fat that's being deposited in the liver and in the pancreas and in the muscle cells and causing problems with insulin dysfunction. Okay. So blood pressure categories, this is just remembering your blood pressure management. Blood pressure management and control must be very tight, and even tighter in a diabetic who has complications. And in persons who have impaired renal function, you really want to get, those blood pressures quite well controlled, or cardiac issues as well. Of course, you don't want the person to have blood pressures that are too low that they're getting dizzy, or they're getting dizzy when they stand, etc. But this chart is really just to kind of highlight, 140 is not a normal blood pressure. We may have thought that of 20, 30 years ago, but it's not a normal blood pressure, and it's very important that your blood pressure is actually treated to target, and that you do not settle for blood pressures that are higher than normal. Remember, hypertension is the #1 cause of kidney failure in Barbados and actually the whole world, and it comes just above diabetes. Very important to remember this, okay? So now we're going to move on to something else you need to take note of, and this will be your lipid profile. Yes, you will want to know what your lipids are, your total cholesterol, your high density lipids, lipoproteins, so HDL. This is actually what they call the protective cholesterol. LDL, that's the one that they say blocks up the arteries, and then something called your triglycerides as well. So you do need to have lipid profiles as opposed to just sticking your finger and just checking the total cholesterol, because it doesn't tell you about what's going on with the rest of your cholesterol kind of fragments. And why is cholesterol important? Because you can have a normal vessel, and then as you have, the cholesterol gets deposited over time, and it's a natural thing for cholesterol to get deposited as we age. But if your levels are high, it's going to be deposited at a faster rate, and you can see how it actually moves on to kind of occlude arteries. And what does that occlusion do in the phase 4? That's what contributes to heart attacks. You can actually have heart attacks when you're at phase 3. And it also causes poor circulation, increased risk of amputations, etc., increased risk of stroke, kidney failure, etc. Okay, so that shouldn't be ignored. And I just want to highlight, however, in persons who have diabetes, because high sugars are directly irritative to the linings of the vessels and it causes damage to the vessels, then cholesterol kind of follows in behind. So even if your cholesterol is what you consider to be controlled and you have diabetes, it's quite possible you may want to, or your care provider may want to lower that further, or at least put you on a medication that stabilizes that cholesterol, because the cholesterol is actually very, what I call fragile. It can almost, the plaques can actually just rupture. And what statins do, and the ezetimibe or ezetrol, is they actually help to stabilize plaques, and they help to almost like melt back the plaques. So it's almost like if you had a pipe and you broke it and you saw calcium in it, those medications help to reduce the amount of calcium or plugging in the pipe or the artery. That's just an analogy, basically. So complications. Somehow it's a slide I always hate to show. Why do I hate to show? I don't know. I shouldn't hate to, but I do. Um, and I think for me, it's simply that we see so many complications, and the complications build up such a negative kind of expectations for persons living with diabetes. It causes an abnormal amount of stress for people who do live with diabetes for fear of complications. And I think what I want to point out here is that if your diabetes is controlled, from early, if you diagnose it early, you do not have to have complications. I certainly have patients with type 1 diabetes for over 40 years who have no complications. I mean, like no complication. And it's possible. And I just wish that we can get more people, I think, in Barbados to actually understand this. You do not have to live the diabetes nightmare that so many people have lived, but you do have to be responsible for your health. Now, diabetes generally damages the body because it, as I said, it causes a lot of irritation or what I'd call inflammation, and this inflammation happens throughout the whole body. The inflammation is very damaging to the nerves and the vessels. Now, remember, we have nerves and vessels from the very top of our head right down to our little pinky toe. So it means that diabetes uncontrolled can cause an extensive amount of damage. And the sad thing about the complications is that it doesn't decide, well, you know what, I think I'm just going to hit the kidney and nothing else. It doesn't work like that. It tends to damage multiple places at one time. So anywhere from the brain with strokes, premature cognitive decline, increased Alzheimer's, eyes, oral cavity, heart with heart attacks, heart failure, abnormal heart rhythms or arrhythmias, your stomach and your digestive system with difficulty swallowing, vomiting, diarrhea, kidneys, sexual dysfunction, both in men and female, and of course, as I said, the nerves anywhere in the body. Nerves control sensation, but they also control movement. So people may actually have difficulty with muscle strength if the nerves that control movement are being affected. And nerve dysfunction can be very disabling, especially if the sensory nerves are in a state where they're causing a lot of pain. That's called peripheral neuropathy. And then, of course, the foot in itself, that's a whole other kind of area on its own. So, you do see a lot. You even get weakening of bones, osteoporosis, increased risk of infection, etc. But I would like to encourage people, not to live a life where you're heading towards, adding on to that statistic list. But even if you have a complication, please understand you can still have an excellent quality of life if you control your diabetes. And I've certainly had patients we've actually seen some of their complications, although they shouldn't be getting better, they just stabilized for a while, for long periods of time, actually several years, persons with kidney impairment. So it's just to understand that you can continue to live a good life, even if you do have a complication, but you always have to think about how do you control your blood sugars and your blood pressure, etc., so that you're not accelerating damage, basically. So I wanted to go into screening, but it's too much to go through in this presentation, but I think this actually sums it up the best. Do you screen for complications of prediabetes and diabetes at least once a year? If you are not doing that, you're not screening for complications. It needs to be done on an annual basis. It's very heartbreaking for us here when we see people who come to us and they have something like kidney failure or kidney impairment, and they didn't even know why. When was the last time you had your kidneys checked 5 years ago? So we can't let these things happen. But what I'd like to encourage you is I want you to be empowered to understand that you do need to have regular screening. And if for some reason you don't get it done, or maybe your care provider is busy or focusing on something else and does, remember, it is your onus. It's up to you to say, actually, when was the last time I had my check for my kidneys? These things matter. If you pick up complications in very early phases with diabetes, sometimes these can be reversible. But if you pick it up late, and late can be anything from 6 months to a year, generally not reversible. Okay, so don't wait until something has been there forever, including for the men, sexual dysfunction. If you're having problems with your sexual function, go early. If you wait more than 4 or 6 months, you're not going to get it back 100%. It's less likely. Whereas if you go earlier, It's more likely if you get your diabetes sorted out really quickly, things might go back to being normal. And we certainly have seen that here as well. So these are just some special considerations I wanted to mention because I know this is a diverse population that's here and older populations. Now, the majority of people that we see who have diabetes are actually older people. Half of our patients here are nearly 58 and over, 56 and over in our audits. Okay, that's half of our population. And, you know, a lot of the times I see patients who come, oh, they're getting old and they're falling apart, but there are a lot of older people who have a fabulous kind of positive attitude as well towards aging. But even I would say I'm not 50 yet, and sometimes I feel like getting old and falling apart, okay? But in older populations, you have to think about things so that you're managing, you know, the diabetes differently, or you're considering certain things. If you're a care provider with somebody who's older, you know, do you remember do you remember when to take the medications? Do you know how to take them? Do you remember where you put your blood sugar machine? So there's simple things that matter so much, you know, if you have a problem like memory loss. Physical challenges, mentioned that before. My back hurts, I can't go walking, my knee hurts, you know, I'm up all night because I'm in so much pain. Declining vision. How do I give somebody a syringe to draw it up when they can't see properly? You've got to think of something different. And if you know you have some of these problems, don't hide behind it. Actually put it up front there and say, okay, this is a little issue here, because your care provider can give you options. There are always options. There's so many options related to medications, devices, how you notify yourself, help, whatever it is. Declining renal function as well, because that might impact on some of the medications that you're using. So it allows you to use it safely. Self-isolation, other fears related to getting older. And then, of course, as you get older, the risk of having low blood glucose events can increase depending on the type of medication you're using. And that's something that your care provider might want to consider very strongly. If you're an old person and you're having repeated low blood sugars, you must bring up to your care providers. Low blood sugars, unfortunately, if repeated, will send you to the pearly gates faster than a high blood sugar. And it's very, very dangerous. So do not sit down at home having 3 and 4 hypos a week and not seeking attention for it. Recently, I met a lady who'd been having hypos for over 20 years, and I couldn't fathom that. You know, she'd been running behind her sugar, and she'd reached a stage where she was not aware when she was having low blood sugars. And she was at home with a grandchild, and they had to break into her house to help her and the 7-month-old child. Don't put yourself in that position. It's not necessary. There are options. Medication-wise. Likewise, just saying, if you have a problem with the medication, there are options. There are several medications and several preparations of the same medication. Please do not be on something that you're absolutely unhappy with or it's giving you side effects. It doesn't mean that you just stop it and say nothing. You need to contact your care provider and find out what your options are. So another area of concern, type 2 diabetes is a rising threat in the youth. And this is something that's quite dear to my heart right now, because we are actually seeing this on the ground, okay? It is an increased risk for developing, as we know, type 2 diabetes and heart disease. But if it's happening in a young person, can you imagine how young they're going to be when they are developing their heart disease? So this says 1 in 5 children aged 12 to 18, this is in America, may have prediabetes. And they've actually found these numbers to be higher in Black populations. And I would say since COVID, we've been seeing children. We had one girl who's 8 years old. We have a 9-year-old. We have a few 11-year-olds. We have 13. We have 14. We have 15. And these are all children with prediabetes. So please feed your children properly. That's number one. COVID has made it very difficult with the lack of physical activity. A lot of these children are putting on a lot of weight. And we need to stop the horrendous trend that we have of all of these fast foods, super processed, ultra processed foods. They're actually damaging our children, and they're going to lead these poor kids to an early grave. And there's something desperate that has to be done in Barbados regarding this issue. And some of these children who come to us, they don't even have first or second degree family member with diabetes. So it's not familial, it's what's happening in their lifestyles and their diets, okay? So now I'm going to go to the other hoo-ha topic, which is COVID-19, which caused everybody a whole lot of stress. And this is just to put a little light on it. I think it's still a tricky situation. I certainly have people with diabetes who are still terrified of COVID. who will not go, they don't go anywhere. And, you know, some of them literally are living in fear. But to understand, you know, I'm going to go to the next slide. COVID-19, the virus basically, it causes damage through activating our immune system. But what happens is the overactivation of the immune system, and then it damages the body basically, or the different organs in the body through that way, if you end up with moderate to severe COVID. The problem with COVID and diabetes, if your sugar is not controlled, you're going to have a case where you have inflammation from the diabetes, and then the inflammation from the COVID, the two of them smash together, and you have a massive over-inflammation in the body, which can be very kind of damaging. But however, if your diabetes is well controlled and you do not have too many comorbidities, your survival rates are certainly going to be a lot higher than somebody who may not be well controlled and has other comorbidities. As I said, this is a very simplified kind of representation of diabetes and COVID. So people, the truth is the stress is real. The last year has made life extremely stressful, even more stressful for you if you're living with an NCD or you're elderly. But even just having diabetes outside of COVID can become extremely stressful. But once again, it goes back to speaking to your care provider, getting the education that you need so you understand and you are working from a position of knowledge and not fear. So this is actually the end of my presentation.
My apologies, 1 second. Can everybody just make sure that their volume is on mute, because I'm hearing some background noise there and it's a bit distracting. It's like a radio or something. Thank you.
Okay, so not to worry, Keisha, I've actually come to the end of the presentation. I know that I've said a lot, but as I said, people are welcome to send further questions if they want specifics answered outside of this session. But I just want to show you, I want you to think about where are you on this post-lockdown kind of spectrum. And I'm just going to share something on a personal level. When we came towards, I would say that almost like the end, kind of like the last shutdown, even me as a doctor, I was actually depressed. I was okay-ish. I was actually depressed before Christmas because I saw it was coming. I knew that we were going to crash with COVID, you know, so I couldn't even enjoy my Christmas. I couldn't tell anybody Happy New Year because I'm like, Happy New Year, 2021 is just going to be COVID on steroids, okay? And then when the ash came, that just kind of pulled me down a little bit further. So, I mean, if I as a care provider am going through this, you know, I know that everybody else is going through stuff, and you have to be real about where you are. Find somebody that you can talk to. We meet lots of patients who have a lot of anxieties, depression. It is extensive, but the point is you must please speak about these things. You know, I think everybody in Barbados is really pulled together to try and help those who were having difficulty pulling through for whatever reason, maybe financial or whatever. But, you know, you have great resources out there, and your organization, Forlam, reach out if you need to reach out. But think about where you are and where you want to go. COVID is not going anywhere, and we have to learn how to live safely with COVID, but we also want to live in a state where we're in a state of good mental health as well. So this is just some tidbits for you. And my final message, really more on wellness, is do you need a medical or screening for NCD? Some people have locked themselves home away during the pandemic, and they've come back to us in a hot mess. A year down the road, haven't seen a doctor for a year, medications out. A lot of people have come back really messy, to be honest with you. Is your NCD controlled? Are there concerning issues about medications? If they are, you need to bring them up honestly with your care provider, and never let anybody tell you, oh, well, the medications causing you diarrhea. Oh, well, too bad, take it. That's not going to work. Why? Because I know you're not going to take it when you're at home. So you need to figure out what your options are, okay? People who have medication issues are generally less compliant with their medication, which means that their NCDs will not be as well controlled. Is there a need for self-management education? Self-management education should be an ongoing process. It's not something that happens at the time of diagnosis, but it's something that should happen over and over again, okay? Nutrition advice. Physical activity plan, targets, thinking about household activity, thinking about the children who are in the house as well. And of course, consider use of your time, your viewing time, your sleep time. This applies to both you and the young people, you know, in the house as well. Because we're spending so much time at home, we spend so much time on a couch in front of TV, or we've disrupted our sleeping patterns so much, you know, so just just some things really to think about. But remember that ongoing medical care remains, I think, paramount even at this time. So this is just a quick slide, really just to show you the gamut of kind of care that we have at the Diabetes Center. We have point of care testing, as you would have with your organization, ECG assessments, physician consultations, registered dietitian, diabetes specialist nurse, who's our specialist diabetes educator. We have a foot clinic, which does foot evaluation, screening, management of callus, nail problems, orthotic recommendations, etc. We have strong links to physiotherapy. We have a relationship with Warren's Physiotherapy. We have cardiology, and we have eye screening as well. And we have extremely close links, obviously, with general surgery, orthopedics, vascular teams, etc. So we have a really kind of tight network here so that we can cater to the vast array of persons that we see who come through here, who may be the person who has diabetes or the child who is obese, to the person who has an amputation or is blind or has kidney problems or other things like that. So I've spoken a lot. I hope I didn't overgo my time, but thank you very much for having me, and I'm happy to take questions.